if I really gave his introduction justice, I would go on for the entire hour. But he is a professor of neurosurgery in our department and the chair emeritus of our department as well. He remains the co-director of the Pituitary Care and Research Center, and his CV is really miles long at this point. He has done so much for the field of neurosurgery and pushing both the safety and efficacy of what we do in the skull base forward over the course of his career. So I'm very happy to now overlap with him in this department for as long as he's willing to stick around and continue guiding us. He is probably best known for his work in pituitary and paracellular tumors, as well as CP angle tumors, most notably acoustic neuroma and hearing preservation surgery for acoustic neuroma. And tonight he'll be talking to us about his real passion project, which is pituitary tumors. So I will bring up his slides now and give him the stage.
Okay, you can hear me, Peter?
Yes.
Okay, so I'm very relaxed and kind of informal. I'm going to cover a lot of material, but I assume that you can come back and look at these videos and look at it more tightly if you'd like. But we should be able to get through it and still have plenty of time for questions. And anybody who wants to ask a question, just pop in and I'm here. Let's go to the slides. So the next slide, Peter. So the pituitary gland, oh, you're skipping too.
Sorry, okay, there we go.
Okay. So the pituitary gland starts to form towards the end of the first month during embryological development. And it comes from two areas. A lot of you know all this material, so I'm going to cover it quickly, but for those of you, it's a refresher. The posterior part of the pituitary gland comes down from the hypothalamic and third ventricular area, while the anterior part of the pituitary gland comes from the roof of the mouth, migrates up, and where the two join, there's often a cleft that's left, and that's referred to as Rathke's cleft or Rathke's pouch. And it's not uncommon to see cysts form, Rathke's cleft cysts. And if you scan everybody walking down the street with an MRI scan, you'll find perhaps 1 out of every 2 or 3 people, I'm sorry, 1 out of every 4, 5, 6 people will have a lesion in the pituitary, often a Rathke's cleft cyst. That means nothing. Let's go to the next slide. So the pituitary gland is in the sella, as you know, and there's a diaphragma cella above the top of the gland that the stalk goes through, and arachnoid does not usually descend into the sella. We normally don't have CSF in the sella. So most of the time when we're operating on microadenomas, the small tumors in the pituitary gland, we're not exposed to CSF. But it's not rare to see opening in the diaphragm where a pouch of CSF comes down into the sella, referred to as a partially empty sella, as demonstrated on the right side. I don't know if you can see. Can you see my arrow? No.
Oh,
you can't
sorry.
see my.
I'll give you remote control. Go ahead.
Can I now? My arrows. You can see it.
Yes.
Okay, so in here, you can see CSF descending into the sella just as a partially empty sella. Next slide. And if you look at the gland, this is a top view of the gland where the stalk comes into it. The anterior part of the gland is larger than the posterior part of the gland. Looking from underneath, that's the anterior gland, stalk way on top, and the posterior gland. And when I'm talking to patients, I kind of describe it as a jelly belly jelly bean size to give patients an orientation into the size of what we're talking about. Next slide. On a sagittal view, a midline view, the sella into the floor of the frontal fossa. The gland, the anterior gland, is supplied in blood by the portal system from the hypothalamus. The posterior gland is more arterial, but the terminals of neurons coming from the anterior portion of the hypothalamus come down into the posterior gland and secrete the posterior hormones there, while hormones are released in the hypothalamus in the portal system that come down and stimulate the anterior part of the gland, and we'll come back to that later. Those hormones are important, knowing what they are as far as medical treatments of some of these tumors as well. Next slide. The normal pituitary gland is made in clusters, sinusoidal capillary form with reticulous structure around these. And later I'll show you a picture or two of tumors. And one of the hallmarks of tumors to the pathologist is when they stain with a reticulin stain, you lose these reticulin structures. And it's very easy then to see a monomorphic cellular pattern to know that it's tumor. Next slide. So in the pituitary, we have obviously anti-hormones, posterior hormones, and it's this kind of a steady state that exists. The anterior hormones are controlled by hormones from the hypothalamus. Posterior hormones are made in the hypothalamus but stored in the pituitary. They come down the axons. And there are positive and negative regulators from the hypothalamus into the anterior gland that will show for each hormone in a bit. But that steady state balance is what you and I like and what is disturbed by tumors. Next slide. The hormones, this is kind of the old representation of the hormones. Somatotrope, which is growth hormone, which then goes down to the liver and causes the liver to secrete IGF-1, which then goes to end organs. The lactotrope secretes prolactin, which goes to the mammary gland, as well as others, but particularly mammary gland for making milk when women are nursing after delivery. Thyrotrope makes TSH, goes and controls the thyroid gland. The gonadotropes, you know, FSH and LH, control the ovarian follicles and the testes in male. And corticotropes secrete ACTH, which goes down to the adrenal cortex to make cortisol. Next slide. And I don't want to go into this in detail, but this is the more contemporary view of the cells in the pituitary, that you have precursor cells, which then are driven by transcription factors. T-PIT goes towards the corticotroph, PIT1 lineage goes towards the somatotroph, the lactotroph, the thyrotrope, and there's some overlap in here which leads to some of the plurisecretional tumors that we see. And the GAT-A2 goes down towards the gonadotroph. But this is how pathologists now are starting to label pituitary tumors and cells. They can stain for the various transcription factors. So reviewing this and becoming familiar and comfortable with this is important later on. Next slide. So pituitary tumors are common. If we do autopsies again on everybody walking down the street, in various studies, anywhere between 10 and 20% of people will have lesions in their pituitary. They're generally small and silent, but they're common enough that actually a number of years ago, maybe 8 years ago, a group of people from the American and European endocrine societies, I was one of the 8, had to get together to write guidelines for what we called incidentalomas. What do you do with tumors that are found on scan that were totally silent? And but I'm going to sidestep that for the moment, just to point out, though, they are very common. They are benign, virtually always benign. The chance of a pituitary tumor being a malignant tumor is less than 1 in 1,000. Pituitary carcinoma is defined by metastatic tumor cells, not just abnormal looking cells in a pathological picture. They have to be metastatic to be called pituitary carcinoma. They're classified as to functioning or non-functioning. If they're making a hormone, it's a functioning tumor. If it's non-functioning, obviously it's not, although in the literature, a lot of the gonadotropes were really called non-functioning tumors because people weren't staining for gonadotropes consistently in the past. And they're classified by size, just arbitrarily. Anything below 10 millimeters is referred to as a microadenoma. Anything larger than 10 millimeters is a macroadenoma. That's a pretty vast spectrum because tumors can be larger than 4 centimeters. Giant pituitary tumors are larger than 4 centimeters. Next slide. There are a couple of criteria when you're talking about the tumors. Obviously, one is which hormone is present, but also how much of the hormone is present. Some of the tumors react differently, both clinically and to medication, whether they are sparsely granulated with hormone, or richly granulated with hormone. We also look pathologically at the Ki67 or MIB1 index, just the mitotic index. Most pituitary tumors are very benign, and when you look at the MIB1 index, it's less than 3%. For a while, we used the term atypical adenoma when the MIB1 index is greater than 3%, but the literature is a little mixed. The majority of the literature does think of tumors that have a greater than 3% MIB index as being a bit more aggressive or atypical than ones below 3%, but that's not absolute. Next slide. So when you look at the spectrum of tumors, the lactotroph makes up about 40 to 50% of tumors that we see. The gonadotroph, or clinically non-functioning tumor, makes up 15 to 40%. Acromegalic or somatotroph tumors make up 10 to 20%. Corticotroph tumors make up 10 to 50%. Cushing's disease. Thyrotropic secreting tumors are very rare. Tumors presenting with hyperthyroidism are really rare. I've seen 5,000 patients with pituitary tumors, taken out 4,000, and I don't have a whole handful of thyrotropic secreting tumors. Next slide. So anatomically, again, on a midline cut, sphenoid sinus underneath, the cella with the pituitary, the stalk going up, the chiasm just above it, obviously pons behind it, but those are the areas that we're concerned about. Next slide. So here's a tumor seen at postmortem that's rather large. Above it is the chiasm. And so this tumor is going to present most likely with neurologic symptomatology. And the most common that we see when the chiasm is compressed from underneath is a bitemporal hemianopsia, as seen in the next slide. That's the more common. It usually starts in the superior temporal quadrants, and as the compression of the chiasm gets more and more, you can get a full hemifield. And in fact, for very large tumors where they have complete bitemporal hemianopsia, you can get a phenomenon called sliding fields, which is an interesting phenomenon for you to look up. When you have total destruction of the chiasm, basically the two occipital hemispheres can't superimpose the images. And you get diplopia from the cortex because of the lack of alignment of the two fields. Next slide. On the other hand, you can have a tumor like this that I took out, which is just maybe 5 millimeters in size. It's a microadenoma. So then the next slide, when we're talking about pituitary tumors, we have to talk about, are they presenting with mass effects where the neurologic issue is the main concern, or are they presenting with endocrine dysfunction, either hyperfunction or hypofunction, and that's our main concern. Obviously, when it's a very large tumor, it's the mass effect that takes precedent over everything. We're more concerned about vision. I, or the endocrinology team, can replace any hormone, but I cannot replace vision. So on a coronal view, anatomically, we have the gland sitting in the cella, stalk going up, again the chiasm, but laterally, the cavernous sinus. And I mean, to all of you, it's very straightforward. Sphenoid sinus underneath, but when you're talking to patients, you have to be pretty clear, explain that there's a major difference between an air sinus and the cavernous sinus. I describe it as an envelope through which runs the carotid artery and a bunch of cranial nerves, 3, 4, 6, and V1. So when you're talking about tumors, again, it's important to know whether the tumor is confined to the cella, whether it's going straight up, is it going out into the cavernous sinus. Even though these tumors are benign, the incidence of cells creeping through the medial wall of the cavernous sinus into the cavernous sinus is very high. It's very common to see that. Next slide. So this is just a coronal view on an MRI where this is the pituitary. Obviously, the carotids are well seen. Sometimes on a very crisp, strong magnet MRI, you'll be able to see the cranial nerves as well. But when you see a lesion like this, this is clearly a tumor in the gland with the normal gland being around it. Next slide. This is the same tumor, but a cut further back showing that the tumor is on the right side of the cella, right? This is a coronal view, so the right side's over here, left here. And we can see the pituitary stalk, and we can see it deviated a little bit off midline, again, confirming that we have a lesion in the right side of the pituitary. Next slide. On a sagittal view, again, tumors are usually very distinct. We can tell them from the normal gland. They may be below, they may be lateral, they may be above, but they're usually pretty clear. Next slide. And they can be pretty large. Look at the size of this baby. You know, that is huge. You know, so it's a different entity than the microadenoma by far. Next slide. On coronal views, or this is, I'm sorry, an axial view, you'll see tumor invading into the cavernous sinus, and we can even see tumor lateral to the left carotid artery here. So looking at all the views to define the exact size of the tumor and extent of the tumor is important when it comes to treatment modalities that we'll talk about later. Next slide. Here you can see the diaphragm sometimes narrowing the connection between the intracellular portion of the tumor and the supracellular portion of the tumor. Next slide. On the coronal view, we'll see the same thing. Makes it a little bit more difficult during surgery. Of course, we would then have to open this diaphragm to get to that portion of the tumor to decompress the chiasm, which you see compressed above. Here again, you see tumor into the left cavernous sinus. Here we see a bit of normal gland displaced towards the right. Next slide. So this is an early classification system. Jules Hardy practiced up in Montreal, and he brought the transsphenoidal operation to this continent from France. And after I finished my training, I had never seen a pituitary operation during residency other than a craniotomy. And I went up and spent time with Jules Hardy, and he was very kind to me, taught me a lot. But this was his early classification system, talking about enclosed adenomas as opposed to adenomas that were invasive through the floor, going laterally. When you talk about treatment, you can't talk about this tumor and this tumor necessarily in the same sentence. So you need to define what you're treating later on, whether you're treating microadenomas or macroadenomas with invasion or without invasion, clearly so that we can analyze our treatment results and know what algorithm is best for different size tumors. Next slide, a more contemporary system of looking at these and categorizing them. Next one, Peter, is the NOST scale. Dr. NOST is chairman of neurosurgery in Vienna and defined his scale in reference to the carotid artery. So a grade 0 tumor is inside the cella. A grade 1 reaches the medial wall and the center of the carotid artery, but not past it. A 2 goes to the lateral wall of the carotid. 3A and B, as you can see, 3A is between the loop of the carotid, 3B inferior to it, and grade 4 completely surrounds the carotid. It makes a huge difference, even with contemporary techniques that I'll talk about later using the endoscope, where we can now open into the cavernous sinus. But you have to think twice and 3 times about, is it worth being aggressive, operating lateral to the carotid where you have the oculomotor nerve and the 4th nerve, as well as the 6th nerve? Is it worth potentially creating diplopia in a patient for benign tumors where we have many successful forms of treatment? As I said, they're always benign. Some a bit more aggressive, but benign tumors. Next slide. So as a theme and pattern with pituitary tumors, the cell has a choice, obviously. It can divide or it can differentiate. Cancers, usually go one or the other. Endocrine tumors are different, and what makes dealing with pituitary tumors so fascinating. Frankly, it's one of the more fascinating areas that we deal with, even though the surgery is not as necessarily sophisticated as some of our vascular and more complex skull-based surgery. But these tumors tend to do both. They proliferate, but they still differentiate in function often. They produce hormones. Next slide. So let's keep that in mind. So let's talk about the tumors. The first very common tumor is a prolactin-secreting tumor. and we refer to it as just being hyperprolactinemia. Prolactin is a tumor that's present in men and women. In women, it causes a secretion of milk during nursing periods. In men, we're not sure what it does. I joke with patients that salmon swimming upstream have high levels of prolactin, so maybe it's how we deal with life. But men who have hyperprolactin sometimes will get galactorrhea and gynecomastia, enlargement to the brain, but that's only about 20 to 25% of the time. In women, menstrual, particularly obviously ovulating women, menstrual abnormalities are seen early. You see these tumors often when they're small in women because of the menstrual irregularity. When men have prolactin secreting tumors, they tend to be very large because men don't necessarily appreciate the fact that there's something wrong. You know, as you age a little bit, your libido may go down, your sexual function may go down, and people think that this is just normal. You know, a 50-year-old guy may think that it's absolutely normal to be losing sexual function, while a woman who's still menstruating knows rapidly whether there is something going on. Next slide. So when you look at the physiology of prolactin, prolactin is secreting in the anterior gland. The hypothalamic hormone that stimulates prolactin is TRH, thyrotrophic hormone. The hormone, or I don't want to say hormone, it's not a hormone, dopamine, the chemical that is the negative control of prolactin is dopamine. Sucking on a breast is a negative. It inhibits the dopamine, allowing the prolactin to be secreted. When something presses on the normal pituitary gland, most of the cells that produce hormones start to lose the ability to produce that hormone. It's the opposite with prolactin, because when something presses on the gland of the stalk and interferes with the dopamine reaching the gland, prolactin goes up. So hyperprolactinemia can often be seen in non-secretory tumors or even cysts in the pituitary that are causing a little pressure on it. Normal prolactin levels up to about 20. If prolactin goes up above 250, we're reasonably convinced that it's a tumor making prolactin, but anything below that could be just anything other than a prolactin pressing on the normal pituitary gland. But seeing the TRH as the stimulator is an important thing to remember in the endocrinology of these, because a patient with primary hypothyroidism who's losing the feedback of thyroid hormones on the pituitary or the hypothalamus will have more and more TRH made, and that can cause the gland to really triple in size and produce very high levels of prolactin just because of the TRH effect. Next slide. So the differential diagnosis for prolactin elevation is a secreting tumor, either micro or macroadenoma. As I just explained, a non-secretory tumor pressing on the stalk or the gland can cause prolactin to go up just by interfering with the dopamine. Any hypothalamic lesion interfering with the dopamine secretion, hypothyroidism, as I mentioned, and some psychiatric medications that interfere with dopamine also can cause prolactin to be up. And obviously, during pregnancy and nursing, prolactin goes up considerably. Next slide. But prolactin tumors are common. They really are common. And in women, they tend to be more micro. In men, they tend to be more macro. And the level of the prolactin often does correlate with the size of the tumor. You know, a level of 150 sounds enormous, considering that up to 20 is normal. But this level is not totally convincing that it's a tumor. It starts to approach the level where we're more convinced it's a tumor, but not always. I've seen levels of 100,000. Next slide. So it's nice when you see a tumor like this. The question then is, what do you do with it? How do you treat a tumor like this? Should you go take it out transphenoidally, or do you treat it with medication? Next slide. In fact, the main treatment these days for prolactin-secreting tumors is medication. Medication called a dopamine agonist. The early one was bromocriptine. Its trade name was Parladel. The more recent one, it's still been around over 25 years, is cabergoline, Dostanex. It's taken twice a week. It's very effective in stopping the tumor from making prolactin. It doesn't kill the tumor. And what I describe to patients is picture a house made of cinder blocks. That's what a cell is like when it's making prolactin. It's filled up. Now make the same house with the exact same number of bricks, but now they're regular sized bricks because they're not making prolactin. They're not inflated. So the house is much smaller, and that's what happens to the tumor. And as it shrinks down, because the cells are smaller, it sometimes tends to scar down and doesn't re-expand in the future. Next slide. Again, this is the slide I showed earlier showing the reticular formation of normal pituitary structure in clusters with sinusoidal capillaries that you see. Next slide. When you have a tumor like this, you have a loss of the reticular structure, you have a monomorphic picture, and it's a totally different picture. And next slide. You can stain these tumors with all types of immunohistochemical techniques these days, including the factors that I mentioned earlier. But here you see the majority of the cells staining positive for prolactin. This is a prolactin secreting tumor. Next slide. So here's a case, a 28-year-old woman comes in with complaints of irregular menses. She used to be very regular. She's having a little galactorrhea now. As an aside, it's usually bilateral, and we're comfortable when it's bilateral. When a woman has discharge from only one nipple, we get a little bit worried that it could be a breast disease, cancer, or something like that. But what sort of workup is in order? As I mentioned, a pregnancy test, a serum prolactin, thyroid function test to be certain this is not primary hypothyroidism. Next slide. And the treatment, there's a little on the presentation, but for microprolactinomas and even for large tumors, our first line of therapy is medical. It's dopamine agonists. Most patients tolerate the medications very well. The dosage is low. With prolonged use of cabergoline, you can read in journals, I think the New England Journal had a report, that when patients are on cabergoline for long periods of time, they can develop cardiac valvular disease. But those are all patients that had Parkinson's disease, and the dosage of cabergoline that they were on was 8 to 10 times higher than the highest dose that we use for pituitary tumors. So valvular disease is looked at, an echo is done, but you don't see valvular disease in pituitary patients. Just go back to that previous slide one time, Peter. So for macroadenomas, medical or surgical treatment is also indicated. Again, usually medical treatment unless the patient is presenting with rapidly declining vision. If they have vision that's, poor, bitemporal hemianopsia, but it's been very slow in progress, we can still try medication. But if someone comes in and they're telling me every 3 days their vision is getting worse, we'll surgically decompress the tumor as much as we can and then go to medical therapy. Next slide.
There's a question that came in the box. How does management of prolactinoma change during pregnancy and nursing?
It's a good question. Most obstetricians and most endocrinologists will suggest that a patient who gets pregnant on the drug, stop the drug. Now, if the tumor was under 12 millimeters in size to start, the incidence of getting into difficulty during the pregnancy is less than 1%. If the tumor is larger than 12 millimeters to start, and then you stop the drug, the incidence of complications goes up a little bit with headache. Some patients will get perhaps a little visual impairment, but most of the time not. But there are numerous reports of thousands of babies born with mothers still taking either the Parladel initially or cabergoline with no increased incidence of spontaneous interruption of pregnancy nor any malformations of the babies. So if a patient is going to stay on the drug, most OB people are more comfortable switching to Parladel because it's got a longer history. That drug started in about 1975 in this country, in Europe before that. And will keep patients on it. But in the majority of the time, the drug will be stopped during the pregnancy. This is an example of a patient that came to me. Look at the size of that tumor. And we just started Parladel or cabergoline while setting the patient up for surgery a day or two later. And the thing started to shrink dramatically. Next slide. That's just after a couple of weeks of medication. It's incredible. You know, how this thing has shrunk down. You can see the chiasm neck, you can see the stalk. It's an extraordinarily effective medication. So there are times when you see a little resurgence of interest towards surgery, when patients don't want to stay on medication long term, they'd rather just have it out and be over with. The problem is that when you take them out, you're not hurt. Generally, an experienced pituitary surgeon will take this out with an extremely low incidence of hurting the normal gland. But the incidence of recurrence, because you're not doing large margins around the tumor, is significant. You can have an incidence of recurrence of 15 to 20% when you go a number of years down the road. Okay, next slide. So let's switch gears from prolactin now to growth hormone. Acromegaly was described by Pierre Marie back in 1886, a pretty long time ago, and you know, this description still exists. Feet are large, including the toes, increased deformities, big person, tongues enlarged, ovibites, all kinds of stuff. Next slide. And normal hand, very beefy hand. It's kind of interesting. When patients come in, when I see patients, I have office hours, I have a nurse practitioner and the endocrine fellow is with me as well. And they see the patient first and they bring it in. And sometimes looking aside, finishing something on the computer, and I reach up to shake hands and I know the diagnosis before I even see the face of the patient. You can feel that beefy hand. It's very typical. I mean, you can have people that have beefy hands. The pile driver, you know, workmen have big beefy hands, but acromegaly is pretty clear. The facial features are pretty clear. Next slide. The separation of the teeth. There's an overgrowth of the lower jaw. You have prognathism. It's a typical appearance. Next slide. So the clinical presentation depends a little bit on the age of the patient, obviously. If it's a pediatric patient, you occasionally will see gigantism. It's not common. The most common pituitary tumor that we see in children is not a growth hormone secreting tumor. Seeing gigantism is not frequent at all. It's usually older people in the presentation of acromegaly. And the tumors
for the students,
tend to
Dr.
be large when we see them. Why? Because the changes that occur slowly and chronically. And people just think they're just changing in their appearance. They think that's all there is to it, that they're changing. I wrote up a series with a colleague when I was at Columbia. One of the endocrine fellows, a series of 125 acromegalic patients. And the clinical fellow who was working with us, an endocrinologist, was first author on the paper. When a fellow works with me and does a lot of the legwork on one of these papers, I get to be last author, they get to be first author. But here he was writing on acromegaly and didn't appreciate his mother had it. I operated on her 2 years later because he just thinks that's mom. She looks like mom. And next slide. It's interesting. You can say, what causes pituitary tumors? And we all kind of believe that something is causing a point mutation in the cell. And whether it's in the alpha subunit or the GS protein or where, no one's certain. But we did a large study on growth hormone tumors and published this from Columbia as well, showing that 30 to 40% of growth hormone tumors do have a point mutation in the GS protein. So I show this, not that it tells you a lot about the growth hormone secreting tumors, but it tells us that I believe that the majority of pituitary tumors down the road are going to be clearly the result of a mutation that can be identified, and it may change the treatment entirely. One of the more fascinating parts of pituitary tumors. Next slide. This is a paper that came out in New England Journal a number of years ago about an AIP mutation in a family, going back to the 18th century and today. Next slide. showing a group of people compared to the normal people beside them. This was a cohort of 140 family members with isolated adenomas in Northern Ireland, and all had that same AIP mutation. Next slide. It's just interesting that to point out that this is an area that people are looking at all the time. We looked at probably 1,000 tumors looking for some type of chromosomal abnormality, and the only one that we saw in our laboratories was the GSP and the Acromegaly. Next slide. I don't want to dwell too much on the endocrinology. So if you look at 100 patients, acral enlargement, hands, facial features, all that will be seen in almost all of them. Soft tissue overgrowth, hyperhidrosis, they all sweat. Lethargy and fatigue, weight gain, paresthesias, carpal tunnel syndrome, joint pains. Next slide. Diabetes, glucose intolerance, interruption of menses, decreased libido. All these things and visual defects in the large ones are typical, but they're so slow and insidious. As I mentioned before, people don't appreciate it. And you think contemporary times, people are more aware of things. We did a study comparing 2 decades, and the presentation was no earlier in the second decade than it was in the first decade. Next slide. So the physiology of growth hormone is secreted in the anterior pituitary. GHRH in the hypothalamus is the stimulating. The chemical that is the negative is somatostatin. And that will be important when we talk about medical treatment, because somatostatin analogs are used to inhibit the secretion of the growth hormone. Growth hormone goes down to the liver and causes the liver to make IGF-1, which then goes peripherally and has various effects. Growth hormone has some effect also, because when we operate on acromegaly and take out the tumor and their growth hormone drops down to zilch in literally an hour. IGF-1 can take a month or 2 to go down, yet patients start to see changes in their hands and face in less than a week. Next slide. So how do we diagnose acromegaly? A random growth hormone is not very specific, because growth hormone is secreted in spikes during the day. So we do one of 2 things, or both actually. We measure IGF-1, somatomedin C, because it stays up. It's stimulated by the growth hormone and tends to be steady state. And also glucose tolerance tests. If any one of you who doesn't have acromegaly were to drink a glass of sugar water, what do you think will happen to your growth hormone? It goes down to zilch. It goes down to about 0.1 nanograms. In someone with acromegaly, you get a paradoxical rise or insufficient suppression of the growth hormone. So these are the 2 tests that we follow, both for diagnosis and for definition of remission after surgery and in long-term follow-up. Next slide. Acromegaly is sort of a subacute disease. It's not as mild as hyperprolactinemia, but it's not as bad as Cushing's disease that I'll talk about next. So you have about a 2 to 5 times increased mortality if left untreated. People don't live into their 90s, they may live into their upper 70s, mainly due to cardiovascular risk and developing of the tumors, the most common of which are colonic cancers and polyps that are precancerous. Sleep apnea is seen in up to 60%. Next slide. The treatment for these tumors is generally multimodality. And what do I mean by that? We have basically 3 types of treatments when we're talking about pituitary tumors. One is surgery, one is medication, and one is radiation. And acromegalic tumors are often so large that we need to use all of them. We take out as much of the tumor as we can safely. We use medication to see if we can control the secretion and normalize the effects of the abnormal hormones. And we often, not often, but we'll use radiation therapy when necessary to prevent growth of tumor in the future. And the medical therapy with somatostatin is not bad. About 70% of people will normalize their growth hormone with somatostatin therapy. It's not 100% by any stretch of the imagination. But again, just keeping in mind that it often is multimodality. Next slide. I'm going to come to the surgery again at the end. But when you talk about medication for acromegaly, we have drugs that will affect the pituitary tumor, somatostatin analogs, or we have drugs that will affect the liver and block the effect of the growth hormone on the liver. What you're concerned about when you just block the effect is that if the growth hormone, if the IGF-1 goes down, whatever negative feedback they may have had on the normal hypothalamic and pituitary axis may be lost, making the tumors grow more rapidly. In fact, that's really not seen. It's not a big worry. And in some patients, we'll use a combination of somatostatin analogs and pegvisomant to treat pituitary tumors, to secrete growth hormone. I go into this because I think to be a pituitary surgeon and to understand pituitary disease, you have to understand the endocrinology, know what your options are, to know what to do with your surgery or your medical treatment and what's best for the patient. You have to be even more familiar with this whole algorithm than the endocrinologists are. Next slide. So let's go to the last group I want to talk about, and that's corticotropic tumors, about 10 to 15%. And this is a young lady. I want to say this is like mid-1995 or something, over to 2000. Typical change, but it's not just that change. You probably have seen people that you know that have been treated with high doses of steroids for other disease that get this round moon facies, central fat distribution. Next slide. But it's a lot worse than that. This is just the diagram of the typical things you see: the central fat, skinny limbs, poor wound healing, diabetes, hypertension. Untreated, this disease can have a 50% mortality in 5 years, not because of the tumor growth, but because of the effect of the high levels of cortisol, unchecked. Next slide. So this is a series of my patients, just showing the percent. 26% came in with diabetes. They all had some weight gain change. 70% had hypertension that was very difficult to control. Depression is a true phenomenon. You can actually see structural changes in the brain in patients that have too high a level of cortisol for a long time. Osteoporosis, very serious. Next slide. So the question is, how do you diagnose first Cushing syndrome? You probably all know that Cushing syndrome is having too much cortisone in the body. When it becomes Cushing's disease, that tells you that the source is pituitary disease. So Cushing's disease is specific. It's a tumor in the pituitary. So this is a complex syndrome. So you need a screen to know that for sure the cortisol is elevated, confirming that, and then trying to localize where it's coming from. Is it coming from the adrenal glands, where it's made? Is the problem in the pituitary gland driving the adrenal glands? Is it an ectopic source, most common of which is in the lung? Also, it can be cyclical at times, when cortisol can be high 1 week and low the next week. There's something called pseudo-Cushing's. The most common causes are depression, alcoholism, and obesity that drives the cortisol up. That's very, very confusing. Next slide. So this is the complex side that maybe you can go back to and look at later. Who should you test? Easy bruising, facial plethora, proximal myopathies, abdominal stria, in children particularly, abnormal virilization, short stature, precocious puberty, and also hypertension leads one to look for this a little bit early. But there's an overlap tremendously between just hypertension, incidental adrenal mass, vertebral osteoporosis, polycystic ovary disease. It's not a simple diagnosis. Next slide. So this is a picture. The yellow is the normal secretion pattern for cortisol in a normal individual. There's a spike in the morning, and it's generally low throughout the rest of the day and then spike the next morning. Someone with Cushing's disease has various spikes, but the level overall is very high. So how can we differentiate this? If we were to draw blood at 8 o'clock in the morning, you can't always tell if it's really abnormal. But if you collect a 24-hour urine and measure urinary free cortisol, the total cortisol in that urine is going to be dramatically higher in someone with Cushing's disease than it is in a normal individual. Also, at midnight, as you can see here, there's a dramatic difference between the cortisol levels in someone with Cushing's disease and a normal individual. So there's a simple test, a salivary swab. Swab the inside of the cheek, you send it off in a box, and it's a very accurate test for telling you that the cortisol is too high. Next slide. So which test? The 24-hour urinary free cortisol, we usually do 2 midnight salivary cortisols. There are dexamethasone suppression dose, both high and low. I don't want to go into that now. These are the 2 big tests to do. Next slide. So once you diagnose that there's too much cortisol in the system, then figuring out where it came from is the big puzzle. Well, ACTH is a good hint. If ACTH is really suppressed in a normal individual, when you secrete cortisol, it suppresses the ACTH. So if you measure someone's ACTH who has very high cortisol levels, and the ACTH is very low, it's a very strong indication that the problem's in the adrenal gland and the pituitary is acting normally. When the ACTH is high, it's telling you it's either a pituitary source or an ectopic source. Ectopic sources are not common. So measuring ACTH is very helpful with that. Next slide. So it's nice when you have someone that has a tumor like that you can see in the gland, but this is more typical of Cushing's disease. You may see a little hint of something, but nothing definitive. More than 50% of patients with Cushing's disease have tumors that are so small we can't see them on the imaging. Next slide. So how do we tell what it is? Well, we do what's called an inferior petrosal sinus sampling, IPSS. Catheters are placed in the veins in the groin, tracked up into the inferior petrosal sinus or cavernous sinus. The pituitary gland is stimulated with CRH. Blood is collected simultaneously from a side of the pituitary and from the leg. Next slide. And next slide. And in someone where the problem is in the pituitary, then you can go to the next slide, Peter. The ACTH is very high, as opposed to ectopic sources where it's the same in the leg and the pituitary. In someone with Cushing's disease, the blood you're getting next to the pituitary is dramatically higher than in the leg. So we do this test in uncertain etiology of confirmed Cushing syndrome. If we thought we had a tumor on the scan, but surgically we failed putting the patient in remission, we'll do that test to be certain of the etiology. If we find that the numbers are very high on one side of the pituitary as opposed to the other, it gives you a hint, but only with about a 60% accuracy. So that's not the best thing. Next slide. And that just tells you if you have a ratio of 3 times the level of ACTH in the pituitary compared to the leg, it's always a pituitary source. It's a very precise test. Next slide. I'm going to go through this more quickly now because we're running close to 9 o'clock. So the treatment guidelines from the Endocrine Society goes through what I was just talking about. If it's AC-dependent Cushing's disease, based on either MRI or IPSS, tumor resection is the way to go. If it's ACTH independent, then adrenal imaging and finding the tumor in the adrenals is the way to go. If you don't see anything and IPS is negative, then looking for an ectopic is another way to go. But surgery for Cushing's disease is the #1 treatment virtually always. Next slide. However, it's not always totally successful. It's hard finding a tumor that's so tiny you can't see on an imaging. I tell patients, try to find a pea in a bowl of green jello without hurting the jello. So the success rates are not that high and recurrences are significant down the road. Not a simple disease. Next slide. Interesting, if you compare the blue here, are patients that had tumors seen on imaging, MRI. The gray are ones that didn't. And the success rate of surgery, this should show 100% over here, is much higher when you can see the tumor. If you can see the visible adenoma, the success rate is, normally in an experienced hands, about 92%. When it's not visible, it goes down to about 80%. So seeing the tumor is a crucial thing, but you can't do it. Next slide. So even if we use radiation, stereotactic radiation, gamma knife, cyber knife, proton beam, again, the results for controlling secretion of ACTH is not great. It may stop the growth of the tumor, but not necessarily normalize the hormones. And this is where, as I said earlier, pituitary tumors are so interesting because the endocrinopathies are the real issue. Next slide. So I'm coming to the end. So there's a need for medical therapy. Remission rates after transnodal surgery for microadenoma is close to 90%. For larger tumors, this would be probably an average, but in very experienced hands, it's closer to 80%. My series is 80%. But you have a 20% recurrence 5 years down the road, suggests that maybe something upstream serotonin system in the brain is driving the hypothalamus. That's not been proven. Fractionated radiation only gives you maybe 60% control. Adrenalectomy will certainly get rid of the hypersecretion, but Nelson syndrome is what happens when the tumor is partially controlled by the feedback from the high cortisol. When you take that high cortisol away, about 30% of patients will have increased growth of their tumor, and the tumor is a bit more aggressive and harder to cure surgically. It's called Nelson syndrome. Next slide. So again, like we talked about for growth hormone, there are different areas that you can use medications on. Anterior, the somatostatin analogs. In the kidney, the adrenal gland, ketoconazole is the more common one, although some of these other are more effective, but not all of them are available in this country. And you even have glucocorticoid receptor antagonists, mifepristone is one of them. So thinking about the medical control, understanding the whole cycle of ACTH and cortisol is important in pituitary disease. Next slide. So TSH-producing tumors, we're going to skip because they're rare. It's an unusual cause of hypothyroidism, but looked at. So to summarize some of the concepts, and then I'm just going to show you the surgery very quickly. Tumors are very common. Many are silent and don't need to be treated, just observed and watched with serial imaging and treated only if they enlarge. Prolactinomas are picked up early in women and respond great to medical therapy. Acromegalics are treated late, increased morbidity because of the time of the tumor's existence. And Cushing's disease, a lethal tumor with an adenoma that's hard to visualize, and the treatment is not simple. It often takes very experienced hands and combination therapy. Next slide. So there are different techniques. For years, we did microscopic surgery where the microscope is outside the head. Now it's more done endoscopic techniques where the eye is inside the head, and you can see laterally, you can see up. It gives you a much better panoramic view. Exposing the cella widely, opening the dura, dissecting around the gland, looking inside. Generally, this is just something that comes with experience, where you're going to look and how you're going to do it. Next slide. So with an endoscopic technique, you're going through the nasal cavity. Oops, back. We skipped 2 slides. Back. So you're going through the nasal cavity, seeing the turbinates. There's normally an orifice at the back of the nose into the sphenoid sinus, and you're just enlarging that. So now, next slide. Medial turbinate, that's the nasal septum. That's going to be the opening, and that gets enlarged. The turbinate gets pushed to the side. The septum gets pushed to the other side a little bit. Enlarging that. Next slide. This is what it actually looks like. That's the front of the cella with the bone open. That's the carotid canal on either side. And top of the gland, you can see the gland very well. And you can aim your endoscope laterally, upwards. Your vision is dramatically better with an endoscope than it is with a microscope. The small tumors that are in the gland, I actually like the microscope better because I have 3-dimensional view with the microscope, only 2-dimensional view with the endoscope. There are 3-dimensional endoscopes, but they're not great yet. Next slide. So here's a large tumor. Next slide. That's what you can do. You can take it out endoscopically and leave an absolutely normal looking gland with absolutely normal function. Next slide. This is one I did with the microscope. That's the front of the cella now. Next slide. That's the bone open. We're now looking at the dura. Next slide. Now the dura has been excised and you're looking at the gland, but notice down in the left lower corner we have a little abnormality down here. That's what a microadenoma looks like in some patients. Next slide. That's the adenoma out. We have a normal, beautifully clean plane. Oops, we went backwards somehow. Clean plane, and that's ideal, to go in there and take it out. I mean, obviously to neurosurgeons, the fun is operating, but in pituitary disease, part of the fun is also figuring it all out and being able to understand what's happening before, during, and afterwards, and helping the endocrinologist handle this. I think that may be the last slide. Yeah. So I know I covered a lot. And I'm happy to answer any questions that you have. I'm not in any rush.
So
Dr. Paul.
hold on a second. We have a couple of good ones from earlier on that I wanted to just pose to you, and then we'll open it up. But
Okay.
one is, how common is recurrence of macroadenoma after complete resection?
Well, complete resection is sort of an artificial term because the only way you can define complete resection is by the postoperative imaging. And that's with an MRI scan. Most people can have an MR. If you need to do a CT, not an MR, you don't see nearly as well. So you're not taking margins around the tumor. You know, if you had a tumor in the middle of your thigh, you take an inch border around it. You can't do that in the pituitary. You have the cavernous sinus to the side. You don't want to hurt the normal gland. But an experienced eye, there is a pseudocapsule around the tumor, which is really compressed normal gland. And if you take that capsule with the tumor, even large tumors, and your scan looks clean postoperatively, the recurrence rate down the road is probably still in the 10 to 15% range if you go out 10 years. But with very large macroadenomas, often complete resection of the tumor is really not possible. My philosophy has always been, with patients and teaching residents and fellows, that this is a benign disease, and you can't make the treatment more dangerous than the disease. So hurting the normal function or the stalk or the carotid artery or one of the nerves moving the eye is a totally unacceptable phenomenon to me. Out of 4,000 cases, I had 2 carotids that were open. Both did okay, but they were very unusual circumstances.
That's great, thank you. And then the other one from the QA box before I open it up was, how common is apoplexy in your experience? And are there any known risk factors?
The incidence of apoplexy varies in different reports. We wrote up our series. When you look at a large series of pituitary adenomas in a large institution, the incidence of true clinical apoplexy is probably around 2%. However, if you look pathologically or an MRI scan at tumors that have blood in them, it goes up to 9 or 10%. So when I wrote up our series, we called it acute and subacute apoplexy. The acute apoplexy was the real syndrome. The subacute was the ones that had moderate-sized blood clots, but no clinical syndrome to go along with it. As far as causative factors, a lot of things have been talked about, but there is nothing definitive that I know. People used to talk about trauma, banging the head. You've seen it with radiation. You've seen it with bromocriptine, but I don't think there's any true one factor that leads towards apoplexy that I can put my finger on.
Okay, any other questions from the group?
Yes, actually, if I can go ahead. So Dr. Post, I was curious to find out for growth hormone secreting tumors, like for that manifests as acromegaly, I wanted to know if when you do the medical or surgical treatment of the tumor, does the patient returns to its normal size phenotypically? Like depending on how old the patient is, do they return to that normal size?
Good question. Well, obviously, bones don't change. So if they've gotten bone growth, giantism as a child, that doesn't change. The soft tissue factors, the facial features, the thickening of the nose and the lips and the tongue do soften dramatically. They may not go back totally to normal, but they dramatically improve, really dramatically. But the overbite, because of the change in the structure of the bone in the jaw, will not change. So, and the diabetes that occurs with it generally becomes much, much easier to control or disappears entirely. We still advise colonoscopy a bit more frequently in patients. It used to be once a year. Now, for normal individuals, I guess people advise colonoscopy maybe every 5 years, depends on age. In acromegaly, we talk about maybe every 3 years. And I still like echocardiograms maybe once a year, watching the heart postoperatively, even if their numbers are normal.
Thank you.
So another one from the box is, what makes a patient a candidate for radiation over surgery? I think we talked about this a little bit, but I'll give that back to you.
The answer to that is nothing. Surgery is usually the first indication for all tumors except the prolactin-secreting tumors. Radiation comes into discussion when you have residual tumor in an area that you don't want to go surgically, like lateral to the carotid artery. So if we have a tumor that's filling the cavernous sinus, we'll resect all the tumor in the sella, above the sella, in the medial portion of the cavernous sinus, but leave the tumor that's lateral to the carotid. At least I believe that's what should be done. There are some aggressive surgeons that try to do that. And when we watch that residual tumor on imaging, if we see any growth in the future, then it's treated with the stereotactic radiosurgery. I mean, there are patients that refuse surgery and refuse medication and will only go to stereotactic radiosurgery, but that's not the first indication. If you have a Cushing's disease patient, let's say, with terrible comorbidities, hypertension you just can't control, diabetes you can't control, 300 to 400 pounds, what I would recommend doing, and we often do, is we'll treat medically first with a drug like ketoconazole, which will stop the conversion to cortisol in the adrenal gland. The comorbidities dramatically improve, and then we'll go try to take out the tumor. But radiation is not used. The only time I use radiation prophylactically is if Cushing's disease treatment has failed, we can't find the tumor, and adrenalectomy has been done. Then often we'll treat the pituitary gland with radiation to prevent Nelson syndrome.
There was a question about post-op DI. How commonly do you see it? And do you have any comments on management?
Well, DI, when you're first learning, you have higher incidence of DI. My incidence of DI in the 4,000 patients was under 5%. And it's usually transient. The incidence of it being permanent is a low single digit, very low. It's probably less than 1%. And
what do you think your rate was in the last 1,000?
Yeah, it's
even lower probably.
There's a dictum I used to teach that a patient presenting with diabetes insipidus is not a pituitary adenoma. It's extremely rare to see diabetes insipidus in a patient who's been untouched surgically with an adenoma. It's very common to see it with craniopharyngioma and other stalk lesions or peristalk lesions, but not with adenomas. But if you looked at large series, and it depends how experienced the surgeon is, for what the incidence of diabetes insipidus is. People will report an incidence as high as 10 or 15% transiently in the hospital, and in low single digits for permanent DI. And the biggest, people's thirst mechanism is normally intact so they can drink, but you don't want someone getting up every hour, every half hour at night. So for a short time, we'll treat with DDAVP at 10 p.m. in the evening just to keep the patient able to rest. I didn't bring up SIADH, that's the opposite. For reasons that are really not known, about 1 out of every 12 or 13 patients post-op, week after surgery, will call, and you can tell from their voice. They feel terrible, they're nauseated, they have headaches, their energy's down, and they come into the ER and they have a sodium of 115 or 120. And that's a syndrome of inappropriate ADH. Some people thought it was part of the triphasic part of DI, but not everybody believes that, and we're not really clear on what causes it. First, we thought it was maybe estrogen loading in young women, but we see it in older men as well. So we're not clear, but everybody that does large numbers, you see that a recent report out of Brigham in Boston from Ed Laws, a very prominent pituitary surgeon, it talks about just limiting the amount of fluid that people drink per day to 1 liter for the first week lessens the likelihood of that SIADH, but we're not sure.
Interesting. There was one other question. Oh, this is a good one, I think, for both of us to answer, but anosmia with pituitary tumors and surgery. Yeah. What is your experience? And then maybe I'll comment a little bit.
In my experience, it was very low. And I'll tell you why, because I was a microsurgeon. I was not a
Like we lost Dr. Post for a minute there. All right, well, hopefully we'll get him back, but I'll comment on the endoscopic experience. I think that for pituitary tumors, it is very low because we typically do not open quite as widely as we do for other skull-based tumors. So for meningioma or craniopharyngioma, a wide exposure is needed, but for pituitary tumors, we can do it a little more limited, and we don't need to take the superior turbinate. We don't need to take the olfactory mucosa in the top of the nasopharynx. So we can almost always spare smell, olfaction.
I'm going to differ a little bit.
Oh, you're back. Good. Okay.
Something happened. I suddenly was out.
Yeah, I lost you for a second.
I moved my arrow off the screen and must have touched leave. When you're operating with the microscope, you're going through one nostril and you have very little mucosal dissection. It's only on one side. We're working through a very narrow microspeculum, so it's a very narrow view. You have 3 dimensions. You're working with 2 hands, very easy. So I'm touching very little of nasal mucosa. So our incidence with the microscopic techniques was extremely low. It was rare for a patient to complain of anosmia. With the endoscopic technique, it's binasal, it's binostril. It's a 4-handed technique. So you need a lot more room for the instruments and the endoscope to go in. So right off the bat, you're moving the middle turbinates at least to the side, typical pituitary. And also the way the surgery is done now, it's a bit more aggressive, opening the skull base, even for pituitary tumors. So to seal the CSF space, which I didn't talk about, a nasal flap is used. So that's a flap that comes off the nasal septum. And so more patients complain of temporary anosmia for a couple of weeks after surgery, but usually it clears. It's rare to see a patient where it lasts long term.
Yeah, I think without a doubt these days the approach is definitely more traumatic for what we do, and I completely agree. It's that the rates of anosmia are definitely higher than they were in the microscopic era. But fortunately, at least for pituitary tumors, permanent anosmia is rare, although not unheard of.
I didn't mention it, but just because Peter's a pediatric neurosurgeon, in children, the most common pituitary tumor that we see is ACTH secreting. Cushing's disease is by far the most common tumor that we see in kids. Not that it's common, but it's the most common in the kids.
I think we have time for one more question. Is that okay, Dr. Post? Any freeze?
Okay.
Okay. So Laura, I'm going to allow you to talk if you want to ask one more question. No?
Hello? Can you hear
Yep,
me?
we can hear. Yep. Laura?
Oh, sorry. Yeah. So I don't have too much experience with pituitary tumors, but I have seen, I'm at UCSF and I've seen Manish Aghi perform quite a few.
Mm-hmm.
And I guess, what are like some of the newest ideas in terms of surgical management of pituitary tumors that you could see, I guess, coming forward in the future?
Well, I didn't get in. I wanted to talk more about the neuroendocrinology with adenomas than about the actual surgical technique. But there are lots of things that are done now that I didn't touch upon. Surgical navigation is where the scan is brought into the computer in the operating room, and through the microscope, you can actually see where the carotids are, where the pituitary is. Your direction to the cella is definitive. You can superimpose tumor margins. So the navigational techniques, Dr. Betterson, our current chairman, is very interested in that, has been a real pioneer in some of the navigational techniques. That's one thing. The use of the endoscope. If I were younger and starting or even in mid-career, I would have been into the endoscope. But the endoscope came, late in my time, and it's a spectacular device to be able to see inside because you can see laterally, superiorly, inferiorly, just angle the endoscope with different head angles, I guess you call it, or eye angles, makes it very different. And also with the experience of more aggressive skull base exposures, allows you to be more aggressive safely with the high suprasellar portions of the tumor. As far as the microadenomas, no, I don't think there's real advancement. All the techniques that we've had, I've had for 20 years. We've tried other things like micro ultrasound probes, and I don't like those. The micro Doppler is certainly very helpful for identifying the carotid artery laterally, but that's when you're being very aggressive and a little less experienced in